In this presentation, we will review the image analysis of the cranium, facial bones, nasal bones, and sinuses for the lateral projection. Image analysis guidelines for the lateral projection of the cranium, facial bones, nasal bones, and sinuses states that when visualized, the sella turcica is demonstrated in profile. The anterior and posterior aspects of the orbital roofs, mandibular rami, greater wings of the sphenoid, external acoustic canals, zygomatic bones, and cranial cortices are superimposed. The inferior and superior aspects of the orbital roofs, mandibular rami, greater wings of the sphenoid, external acoustic canals, zygomatic bones, and cranial cortices are superimposed. For the lateral projection of the cranium, the postero-inferior occipital bones and posterior arch of the atlas are free of superimposition. An area 2 inches superior to the external auditory meatus is at the center of the exposure field. The outer cranial cortex is included within the exposure field. For the lateral projection of the sinuses or facial bones, the zygoma and greater wings of the sphenoid are at the center of the exposure field. The frontal, ethmoid, sphenoid, and maxillary sinuses, greater wings of the sphenoid, orbital roofs, sella turcica, zygoma, and mandible are all included within the exposure field. Lastly, for nasal bones, we should demonstrate the nasal bones with the surrounding soft tissue, anterior nasal spine of the maxilla, and the most anterior aspects of the cranial cortices, orbital roofs, zygomatic bones should be included within the exposure field. So let's just talk about a few positioning landmarks and central ray angulation that we need to establish. When positioning for the lateral projection, you want to make sure there's no head tilting. So you want to make sure that your interpupillary line is perpendicular with the IR. You're also going to adjust the chin as needed to bring the IOML perpendicular to the front edge of the IR. For the cranium, your central ray is going to be perpendicular to a point 2 inches above the EAM. When taking imaging of the facial bones and sinuses, the central ray is going to be perpendicular midway between the outer canthus and the EAM. For nasal bones, the central ray is going to enter a 1/2 inch inferior to the nasion. I have included the image analysis guidelines for you to review at your leisure. So let's talk about cranium rotation in the lateral projection. Rotation results when there is distortion of the sella turcica and it situates one of the mandibular rami and greater wings of the sphenoid, external acoustic canals, zygomatic arches, and the anterior cranial cortices, one anterior to the other in a lateral projection. So when you're seeing almost like a double image, there's some type of rotation. Unfortunately, it is a little difficult to distinguish, which way the patient is rotated from the other. Because the two sides are identical on an image. So you must really pay attention to how you position the patient prior to exposure, and then go back out, ensure that interpupillary line is perpendicular with the IR, and that your mid-sagittal plane is parallel with the IR for to correct the rotation. This is just another demonstration of rotation. As you can see, the orbital roofs and the anterior cranial cortices are not superimposed. So we have rotation in this image here. So let's take a look at cranium tilting. Cranium tilting is identifiable on a image that you have taken. Remember that we want the mid-sagittal plane parallel with the IR. So when the interpupillary line is not placed perpendicular to the IR, we have tilting. And so how do we determine this? Tilting can be distinguished from rotation on lateral projections by evaluating the superimposition of the orbital roofs, the greater wings of the sphenoid, the external acoustic canals, the zygomatic bones, and the inferior cranial cortices. When the head is tilted, these structures will be demonstrated one superior to the other. So how do we determine which way the head was tilted? Through the evaluation of the degree of atlas or C1 vertebra foramen visualization. If the top of the head is tilted towards the IR, the foramen will not be visualized. And if the tip of the head is tilted away from the IR, then the foramen will be visualized. You'll be able to go back out and correct this head tilt and align that mid-sagittal plane parallel with the IR with the interpupillary line perpendicular to the IR. So let's take a look at this practice analysis for the lateral projection. We can see that the orbital roofs, the EAMs, and inferior cranial cortices are not in a proper alignment for a lateral projection. They are actually demonstrated one superior to the other's corresponding structure. So this should indicate to you that we have some head tilt here. Next, we need to determine, do we see C1's vertebral foramen? And we do. So that means that the head was tilted away from the IR. In order to correct this, we need to reposition the patient so that the interpupillary line is perpendicular to the IR, leaving the mid-sagittal plane parallel with the IR, tilting that head towards the IR to achieve this, positioning error. The correction of the positioning error. If there's any questions or concerns, please feel free to reach out to me via email or at clinic. This concludes the presentation. Thank you for participating.